think he's here. Dr. Wiener, who's also not here, he's at a tox meeting, the European tox meeting, and Wendy Chan for their assistance. So our case, a 34-year-old female with a history of CHF, mitral valve replacement, and depression, brought in by EMS for a intentional ingestion. Somewhere in the documentation later on mentions the EF of 15%, which struck me as extremely odd for a 34-year-old, but later on, the inpatient team got more history from the family, and she turned out to have recently been diagnosed with postpartum cardiomyopathy. These are medications. Unknown dosages. There is no PCR from EMS, but in the documentation, no dosages of the medications, unknown how many of each that she took. All 3 bottles were empty. Estimated to have been somewhere roughly an hour and a half before EMS was called. Her parents came home, they found her acting strange and found an empty pill bottles, and she said she wanted to kill herself. That's when they called EMS. Let's get into our initial assessment. So everyone that comes in, first thing we do, primary surgery, right? Her ABCs are intact. She's awake, talking, a little lethargic, a little confused, not really sure what happened or why she was in the hospital, but perfusing well. Vitals, a little tacky, but otherwise nothing that unremarkable. For all of our juniors, especially our new CCT seniors in the next couple weeks, any tox patient that comes in immediately, you want finger stick EKG, right? The finger stick was fine, and here's her EKG. Anyone take a stab at it? Don't all volunteer at once. So in general, so you guys know what you're looking for on a tox EKG. We'll get more into this later, but just to keep moving, no signs of any ectopy, no PCs, PVCs, normal sinus rhythm, normal axis. You're looking at the complex, QRS complex, which it's tough to see on the screen, but looks narrow, roughly 120 or so milliseconds. You can see the QT segment is greater than half the distance to the R, right? So prolonged QT. And no terminal R waves in AVR. And otherwise, just some non-specific ST changes, inferior leads and V6. So exactly, the QRS was actually 126 milliseconds. We'll talk about why that could be significant later on, and the QTC is 513. We don't have any old ones for comparison. So what's our problems, right? So something cardiac, right? System-wise, cardiac, right? She's a little tacky, maybe some conduction disturbance. We don't know if this is old. It's just from her decompensated heart failure. We have toxic ingestion. Sorry?
Altered mental status.
Absolutely. Altered mental status. We have a toxic ingestion and her psych issues. So off the bat, we want to address these individually the best we can. Poison control was called. For our new CDC seniors, it's the perfect time to split your team up. Assign one person to calling tox, have one person with the patient, one person maybe calling the family, trying to get more information. Sodium bicarb was given. Anyone know why? Not
QRS formulas.
right. So this is mostly in sodium channel blockade. Bupropion it is a neurotransmitter reuptake inhibitor. So dopamine, norepinephrine, dopamine, lesser extent, serotonin. But at higher dosages, it can actually have a sodium channel blockade effect. And anything greater, QRS greater than 100, these are considered high-risk procedures. So bicarb was given, bedside echo was done, showed poor cardiac contractility, and the patient was on 1-to-1. So we'll quickly go over a physical exam, and then we'll touch on some of the tox-specific stuff. for physical exam findings. No distress. Mucous membranes were moist. There's no reference to pupils or extraocular movements, but it's something we always want to be cognizant of in our tox cases. And we want to document. Pupils are constricted, dilated, reacted to light. Is there any nystagmus present? These all can help you identify what could have been ingested, since sometimes we have no idea. She's a little tachycardic. They also want to palpate a pulse as well. Heart rate on the monitor is like 1 in the low 6, something in the low hundreds, but again, a lot of times it can pick up ectopic beats, PACs, PVCs. Who knows if that heart rate's actually real, so I would always just correlate with the pulse. She has a prolonged QT. Good thing is that she already has an AICD in place, and she has a sternotomy scar from her mitral valve replacement. It's a little tachypnic, but lungs were clear. Belly exam was benign. You always want to listen for bowel sounds. I've probably done this maybe like 3 times in all residency, but in tox patients, this is actually important because one of the mainstays in management is decontamination, which we'll also get into later on. And lack of bowel sounds on auscultation is actually contraindication to some of the agents we use for decon. No edema, no diaphoresis, and again, a little lethargic, kind of confused, but no deficits on your exam. Patient has a seizure right in front of the CCT team. It's given 2 milligrams of lorazepam, but seizure actually resolved prior to getting lorazepam. Got her sodium bicarb, and now EKG is repeated. Fairly unchanged, a little more non-specific ST changes, but complex looks roughly the same. Again, no terminal R's, and QT segment looks like it's still roughly greater than half the R to R. So her rate slowed down. She got a little bit of fluids. She's now in the 70s. QRS roughly the same. QTC, now it's 534. The left side is the initial EKG. The right side is the no one. Not really any significant change. There was a recent study, like in circulation, where they estimated that created a change of every 10 milliseconds of QT prolongation is associated with a roughly 5 to 7% increased risk of torsades. But she has an AICD in place already. Any questions so far?
Do you know if the bupropion was the extended release?
It's a great question, and this is why dividing and conquering is so important. The CCT team did not know initially. Family was actually, someone got in touch with the family from the MICU team. Patient was admitted somewhere around 3 a.m., roughly like 6, 7 in the morning. MICU got in touch with the parents, and it was Wellbutrin XL. Labs are now trickling back. A little hypokalemic, the lactate of 4.7, AFR. Hyponatremic. Again, first visit, so it could just be from their poor CHF on top of the Lasix ingestion. Potassium 3.5, but this was moderately hemolyzed. She had a gap of 15. CBC was fine. Rest of her labs, fairly unremarkable. All of her levels were negative. INR is 2.2, but she has a mechanical mitral valve, so actually subtherapeutic for her. CT head is fine, and chest X-ray was as expected. Mildly dilated heart, AICD, sternotomy wires. She ended up getting a second dose of lorazepam because she was getting very agitated and started becoming hypotensive. Not really sure to make of these vitals. The blood pressure was, we trended, it was dropping before she actually got that event. So it was about maybe 3 readings in the 80s over 60s, but it was never a tachycardic. Heart rate was in the 70s the entire time. Not sure how accurate of a reading that is.
Just going with the OB blood, UCG was negative.
Wait, sorry?
UCG?
Yes, negative. But she was put on pressors I think she got less than a liter because of her cardiac condition. But now she's more lethargic and no longer protecting her airway. So it's no secret what happened next, right? She's intubated, started on propofol drip for seizure prophylaxis, and she's on Norepinephrine. Repeat labs, potassium was a little worse, and now lactate's 8.5. This is after the seizure. So this is our updated list, right? Vast majorities can all be attributed to her ingestion, with the most recent updates or additions to her problem list. And now she's on mechanical ventilation, hypotensive, which actually responded very quickly to norepinephrine. Also hypokalemic, hyponatremic. Poison control recommended stopping sodium bicarb, right? She's hypokalemic, makes perfect sense. We don't want to make her any worse. And whole bowel irrigation, which is pretty cool, and we'll talk about later on. MICU, nothing very useful. Admit, following everyone else's regs. And neuro wanted to load with dilantin, which in a toxic ingestion doesn't really play that big of a role. And then the usual, right? So, EEG, MRI, and other stuff. ED course, everything we kind of touched on already. Potassium depleted. Admitted to NICU, received 24 hours of whole bowel irrigation. Electrolytes were depleted, got more potassium, got magnesium. She was admitted around 7 in the morning. Pressors were stopped later on that day, and was extubated the following day, on day 2. This slide has nothing to do with the case. I just thought it was hilarious. So she was extubated later on that same night, became very confused and agitated, and as all our agitated patients do, became Houdini and broke out of her restraints. She kicks her one-to-one in the chest and makes her run for it, and was tracked down by security and brought back to the unit. You have a question?
Is there anything with giving dilantin for something that's also
Wait, sorry, say that louder?
Something with giving dilantin, loading dilantin for the seizure prophylaxis, do they have a sodium channel blocker on board?
So actually, that's a great point. So giving dilantin in phenytoin in the setting of sodium channel blockade, specifically with bupropion, can actually increase risk of seizures. So she was loaded with dilantin. Neurology recommendations, they would start TID, but when the attending saw her in the morning, they stopped it. But in general, we'll talk about management of tox-induced seizures. These don't really have a role in the first place. So what do we do in general when patients start becoming a nuisance? Get them out as soon as possible. Immediately downgrade the medicine, seen by psych and accepted to our building, but there were no beds available. So she kind of hung out on medicine for a few days. So we'll talk about tox ingestions. Any question about the case so far? All right. We'll talk about a general approach to the tox patient. We will touch on GI decontamination, but we'll only focus on things relevant to this case, since GI decon can be an entire lecture in and of itself. And how do we manage these patients? The vast majority of them just need good supportive care, but there are certain cases where depending on what's ingested, we can do a little bit more. Any seniors, how do you guys approach tox cases? Anything you have in mind, like your own algorithm or anything? This is kind of the way I think of it, and again, this isn't like gold franks or anything. We stabilize people, right? So what we do, diagnostics-wise, we typically send the same things. We send our tox levels, acetaminophen, aspirin. You always want to send a VBG because you want to know the pH, right? I send the chemistry, specifically for the anion gap. And then our UCG. And that's pretty much all you really need in tox cases. You can send a CBC, it's not really helpful in anything, any tox ingestions. You can send a comp. LFTs aren't helpful in any tox ingestions. If you take a gargantuan dose of Tylenol, LFTs aren't really effective for at least like 24 hours or so. But maybe if you want to know a baseline, they'll probably be helpful. And UCG. everyone always wants a U-Tox, but it hasn't been helpful for me in 3 years. I don't think it's helpful for us at all in the ED. Maybe if this is someone's first presentation of altered mental status, and you're differentiating between some new onset psychiatric problem versus something tox-induced, maybe, but again, that's not for us to decipher. That patient's gonna go to medicine and they'll figure it out. For management, first things first, we protect ourselves. Not very relevant in this case, but in our tox patient that come in with some cutaneous exposure, whether it's organophosphates or something else, we want to decontaminate, want to limit as much harm to the patient as possible, and then our management, depending on what was ingested. So we stabilize, and if you talk to Dr. Wayne, he always has this sort of extended ABCs. D, not really giving everyone dextrose, but just a reminder, get a finger stick on everyone. EKG. F is actually for physical exam. And Foley for our anticholinergic toxidromes. With decontaminate, we always want to get our tox people on board. Dr. Wiener actually gives his cell phone number out to everyone, and he's happy to get calls, whether daytime, middle of the night, for any questions tox related. And I for management, or antidote. These are three we'll focus on. The tox, EKG, GI decon specific to our patient, and any additional management. So we kind of touched on some of the things we look for in a tox EKG. This was a study done by our Poison Control Center at NYU. So all the things we know about EKGs in tox patients are from case reports. This is the first prospective study looking at EKGs in tox patients. They were looking at adverse cardiovascular events, which they defined was a composite endpoint of any of these: hypotension requiring vasopressors, myocardial injury, they defined as an elevated troponin, dysrhythmias, specifically only looking at VTAC or VFib, and cardiac arrest. Having a long QTC had a significant association with having one of these adverse events, even at the standard upper limit of normal, which they use at 470 for women, 450 for men. But when they increased it to greater than 500, the association was found to be more significant. Interesting to me, there is no difference in the mean QRS30 length in their two groups. The two groups were the tox patients that had these adverse cardiovascular events and the tox patients who did not have any. Then they narrowed their endpoints they were looking at. So they ignored hypotension, ignored elevated troponins, only looking at VTAC, VFib, and arrest, and found a little more factors that made these significant. So QRS actually was found to have an association here. And the farther down you go, they tend to be more significant with increasing odds ratios, but it makes sense, right? Because they're just casting their net wider and wider. So you go from having a widened QRS, a widened QT, to now all ectopy, and all EKGs or rhythms that were considered non-sinus. The whole purpose of this was to identify certain risk factors that certain characteristics that you can now categorize as high risk, low risk, etc. for one of these adverse events. The characteristics that had the highest risk was ectopy, and this was all ectopy. Atrial or ventricular. Anything that was considered non-sinus or QTC greater than 500 was considered moderate risk. And having a long QT but less than 500 was considered low risk. Here. Any tox patients who didn't meet any of these criteria was considered very low risk.
Now, 2 slides back. What is the difference between a non-sinus rhythm and a dysrhythmia?
So dysrhythmia, they defined as only looking at VTAC or VFib. Anything non-sinus, you can have different conduction blocks, you can have different, primarily I'm assuming conduction blocks here.
Junctional escape, ventricular rhythm. Good.
So any questions about EKGs? Alright.
Is the presence of ectopy like any ectopic beat, like 1 PAC, put you in the
So-
high risk category? Or is
Yeah,
it
so they-
all ectopic beats?
Yeah, so they define as all ectopy. They didn't exactly have a specific number of PACs or PVCs to be included. Yeah. So moving forward to decon, there's different types of decon. There's a cutaneous, local exon, GI. This is actually a direct quote. He's not here. I forgot. Actually, a direct quote from a guy's last Tinder date. Or one of our juniors after intern Tuesday. There's different types. Gastric emptying, there's different forms. Ipecac, which is prehistoric and should not be given. GI lavage, charcoal, whole bowel irradiation, and cathartics, which essentially just give you diarrhea, increasing GI transit time. We'll focus on the ones most relevant to us. Ipecac we'll ignore, we'll save that for a tox-specific lecture, but should not be given. And cathartics really have no use. One dose considered acceptable, but have never